So I think we are going to start. Well, welcome to the Innovative Discovery Series. And we are honored and delighted today to have Dr. Abate Marco to give us a talk about mindfulness. And I know she came a couple of years ago already, and I've heard that it was a fabulous talk, so I cannot wait. So before I introduce our speaker, let me go over some housekeeping issues. Please make sure that you sign in, and please RSVP so that we can better prepare for the food, specifically for the next session. Unfortunately, there is no CME credit today. Next week, we have Marcela Devoto from CHOP speaking on genetic analysis of neuroblastoma. Then the following week, there will be Thursday Tech Talk when our own Zhu Guizhang will feed our minds with survival analysis. So that will be also very interesting. I really encourage you. That's on Thursdays at noon also. So to our speaker, Dr. Abate Marco is professor and vice chair of research in the Department of Obstetrics, Gynecology and Pediatrics at the Sidney Kimmel Medical College at Thomas Jefferson. And she obtained a PhD in health studies from Temple University in Philadelphia and a master in social work from Rutgers in New Jersey. So in addition to being professor and vice chair of research, she is also the director of the Maternal Addictions Treatment, Education and Research in the Department of Pediatrics at Thomas Jefferson. And she's also the chief of the Division of Pediatric Population Health Research in the Department of Pediatrics at Jefferson, as well as at Nemours, the Children's Hospital here in Delaware, where she directs, mentors, and guides all population health research conducted in the faculty of the Department of Pediatrics. She also plays a very important role in our Accel-CTR grant, in the Accel-CTR program. She's a lead mentor for the mentored research proposals, or MRDA, that are submitted for funding. Since 2012, she has been the Director of Evaluation for the Centers for Medicaid and Medicare Innovation Asthma Project at Nemours. And she also had many other responsibilities, including teaching and mentoring, and there are too many to describe. She has multiple awards. She's been a reviewer for multiple federal study sections as well as for PCORI. She has a very long list of publications, and she's also the PI on multiple federal and foundation grants. So thank you so much, Diane, to be here to talk to us, and we are really excited about this subject.
Thank you. Certainly doesn't feel like me when I hear that, but it actually feels like someone else. Just a couple of words before we start, a couple of thoughts too. One is, if you find that this is interesting, I will be here. I will leave time for a conversation if we want to have question and answers. You can interrupt me. I have 5 kids and 12 grandkids. I've been married 40-something years. My husband knows the exact. So I'm used to being interrupted. I don't. It's normal. And then if there is a sort of thinking that you'd want to get together and meet and talk about mindfulness interventions or mindfulness education, I'm going to set. You can get in touch with Sarah Fay, tell her, and she could have me come back and meet with you all together. And I'll stick around for a little bit afterwards. So before I start, I just thought, if you're eating lunch, I'd really like you to enjoy your lunch. That means in mindfulness, we say really tasting your lunch. You can't really taste your lunch and concentrate on me, but you might take turns tasting your food and listening to me. And I would be really happy if you really just tasted your food. So mindfulness. I'm going to talk about 2 interventions. One's a large, federally funded intervention that's just coming to the end. In fact, we're in the no-cost period extension for what we didn't spend to make sure that we have the right numbers of controls. We recruited a good number of intervention subjects. We had trouble with the controls, but we're doing well now. And the second, and that's the large federal fund project on with pregnant women who are in treatment for opioid use disorder. And then the other project I'm going to talk about was a small pilot, and that is with women who were determined at risk for preterm birth, and a 6-month mindfulness, 6-week rather, mindfulness course with them. And that was funded, interestingly, by the state chapter of the March of Dimes. Both of these studies are now we're doing the analysis and we're submitting other grants. Oh, what did I do wrong? I don't want. If I just hit the middle button, will it go? Okay. So, you don't do this stuff alone, right? These projects are not about one person. There may be one person speaking, but actually the project is really successful today with the complex medical and social issues of the population we're dealing with. You really have to be do trans collaboration. And this is what these slides shows. I just want to mention the co-Is on my study are Doctors Chung, a pediatrician, Lanu, who's a psychometrician, Hand, who's an experimental psychologist and behavioralist, Mike McKenzie, who is, many of you might know, a kinesiologist training, but he is a wealth of information on mindfulness and intervention. Carol Kaltenbach, who was who I took over from, she ran the program I'm running now for opioid addicted women for about 25 years. Megan Gannon just got her PhD, but did her dissertation and has several papers coming out on this work on the parenting piece. And Vanessa Short just published a paper last week. She's our postdoc, and she published on stress, and I'll talk about some of that research. And I'm very grateful, too, that Nemours, Thomas Jefferson, and UD are all represented in that grant. In the mindfulness in pregnancy, it was a much smaller amount of money, like a drop in the bucket compared to a large federal grant. It was the co-PI, it was Janet Katov. Janet Katov is a epidemiologist at McGee in University of Pittsburgh. Doctors Gannon and Short also were co-Is on this study. And Janet's work, she's at University of Pittsburgh, McGee's Women's Institute. Also, Janet's my best friend for 35 years, so that makes me really happy when I see her name on one of my slides. No, I'm still not getting this. I don't know what I'm doing wrong, but whatever I'm doing.
Just use the keyboard.
Yeah, okay, good. Okay, dummy, just the key. Okay, we got them. Okay. So the background here, talking about what the opioid epidemic, it's in the news, you know it because you have a lot of patients. How many of you are working with patients with opioid addiction directly? Okay, so for those of you who aren't or too shy to hold up your hand, you are seeing them every day. You're passing them in the hall. They are getting blood drawn by you. They are paying their bill or complaining about their bill. It continues to be a rising epidemic. We're looking at what used to be 1 in 1,000 births. Now it's actually above 6 at this point. And there are a lot of barriers for these women. So before we even begin to talk about the research, I'm just going to challenge you a bit on your own thinking. You're not sharing this with us or with me, but I'm going to say some words. I'm going to ask you to just kind of think about the image in your mind when I say something like the word addicted, or addicted woman, addicted pregnant woman, opioid addicted pregnant woman. heroin-addicted pregnant woman. And you can take a really deep sigh and have some self-compassion for what is the normal judgment that comes up for us in this for many reasons. I mean, first of all, a little embarrassing that we're, a wealthy country, an industrialized country, and we still think of drug addiction as a criminal or a social issue rather than a clinical issue or medical issue or a disease. But I want to just talk a bit about my moms and how I learned to be less judgmental about them. So what we're talking about when we're talking about women who are opioid addicted, and I'll show you some statistics as we move on, we're talking about women who were had suffered multiple trauma in their childhood. There are multiple traumas. For most of them, the trauma continues because they're vulnerable and they're poor. We'll go into specifically what their trauma history may look like. But at this point, then they come to, in my case, they come to the ED at Jefferson because we're well known throughout the city for treating opioid addicted pregnant women. So they come to the ED, and the ED docs quickly want to get them up to L&D to stabilize them. The women come in saying, no, excuse me, I am not, just detox me and I'm on my way. So a whole health system has to, in their 5-minute segments of time, try to explain to this woman the complexity of the healthcare treatment that she's going to receive, both clinically, medically, and behaviorally. For the most part, the majority of these women want this child. And so to have this baby, they're willing to do what it takes. And they get themselves up to labor and delivery, and they go through that misery of stabilization, okay? On the other end of it, they have medical-assisted treatment. For the majority of women, it's been methadone, but buprenorphine is moving up there, and we're starting to see more Suboxone prescriptions. So when they come into Family Center, which is the outpatient clinic that I run, they come in very nervous. They have a newborn baby. Their baby has just more than likely had neonatal abstinence syndrome, where the baby has been screaming, has had gastrointestinal issues, neurological difficulties, and this woman is taking care of this baby. I just want to challenge you and challenge the people you talk to about addiction, that if this is not the most courageous person that you've ever met, then you're looking at courage the wrong way. Because what we're saying is that this woman, with all of the trauma that brought her to her addiction, has now gone through all this pain of no longer being, for the most part it's heroin, although it could be other opioids, but it's primarily heroin, gives up her drug to have this pregnancy, and is going to be in recovery with everything that she had that led her to that drug to begin with. So this is a courageous and brave woman. Difficult to deal with for those of us that deal with this population. They are a tough population. They're angry. But this is the population that we actually brought in to mindfulness. So here are the scientific gaps. And I know I'm like preaching to the choir on this, but I think it's important to articulate it. There's very little funding or research around the prevention of adverse childhood experiences, and there's more, but not a great deal on social, emotional, or cognitive impairment, and how do we prevent that, or the adoption of high-risk behaviors, where the funding, where the money is, not just funding, but is at the treatment level, right? So disease and early death. And I think that's important for us to realize. So when we talk about ACEs, that's what we're talking about, adverse childhood exposures or experiences. I'm going to talk about them both in the mother and in the child, so we understand what we're preventing. So when we're talking about in the children, we're really talking about preventing toxic stress. And what is toxic stress? It is these ACEs and their effect on the brain architecture. And that effect on the brain architecture and the long-term exposure to toxic stress is that the brain changes, people become more reactive, and people also become sicker. Folletti started the ACEs research, and now there are over 3,000 papers showing that there are ties to ACEs to lung cancer. In fact, if you have a patient with 6 ACEs, 6 or more, you're really looking at somebody who's going to live 20 years less than a person who didn't have that rate of trauma. And I think that's important. But just to say something positive in this discussion is children who are faced with toxic stress. The research also shows that if there is a strong, healthy adult in their life during childhood, they can really stop the toxic stress and actually reverse the effects of toxic stress. So I think we have to think about, whenever we're thinking about issues that are kind of complex, that might really just stress us out, we're enormously resilient. And that's one of the reasons why mindfulness has a role to play. So this is the bigger study, and I'm not going to talk about the whole thing, but maybe I'll come back next year and talk about the whole study. Since I get invited back here, and I always feel so good when I'm coming here. I'm going to just stay with the mindfulness-based parenting. That's really what I'm going to talk about today in terms of findings. Okay. So what we're seeing is that mothers with substance abuse, they're really known for they have high-risk parenting styles and enormous deficits. And you can imagine that there's ambivalence in this population about their child. The child is born screaming, crying. There's a lot of judgment in the postnatal period while the child's in the NICU. A lot of judgment, unfortunately, by healthcare workers, by volunteers, by their own families, for seeing this child. And it's a horrible sight to see a child with NAS. I don't know. How many of you have seen babies with NAS? Yeah. So it's a horrible thing to see, and often as humans, when we do see something horrible, we like to figure out someone to blame for this. So it's not inhuman, unhuman. It kind of makes sense. But they don't really, these moms are not able to pick up on issues like signaling behaviors. So a child crying and what that crying means. What it means when a child starts to reach for its mother. These mothers don't know how to read that behavior. In fact, the example that I often give is, and I've given this before, our moms, when they come in, when the babies start to cry in the clinic, or even in the group, the mindfulness group, you'll often hear mothers say, "She's just like my sister. She pushes every button in me." And then you look down and she's holding a 6 or 8 week child. So there's this this unrational way of attributing the child's behavior to punishing the mom. Or he's just like his father. He's just so unhappy. So trying to change those attitudes is going to be key in helping these women become better parents. What we end up wanting out of this is for parents to be able to touch, to caress their children, to use soothing voices, and show individualized interest to that child, and not attribute and see that child as separate from them, but something important to them. And so this is what is in the mind of the mindfulness-based teachers as they're teaching them. Mindfulness parenting, and what, basically what is it? It's a relational parenting intervention approach and calls for full attention of the parents when interacting with children. A little side story is I also do this with physicians and their staff in pediatric practices, asking them to join in meditation so that they can pay careful attention to the patient they're with, as opposed to the patient that they just came from, or as opposed to the patient they're going to, or as opposed to their chairs, having a fight with their chair in their head in the office. So that kind of attention is very difficult for someone who is in treatment for opioid addiction, and it is a challenge for them. But the other pieces that we're bringing to this is teaching them about non-judgment, and the big focus, and some of our recent findings in the last couple of weeks are showing that self-compassion may be the door into this. We don't talk a lot about self-compassion in the United States. We don't talk about compassion in general. We tend to, in the medical world, talk about empathy, and that's really important, but compassion's a little bit different. Maybe we'll get a chance to talk about that in a bit as well. Self-regulation, well, if you've been addicted to a substance, self-regulation is a real tough one for you. And so we're bringing this. And then cultivating emotional awareness of what's going on with you. That's the other. Let's go back. There we go. So we see mindfulness all over. I don't know if you got to see, twice last year they showed it. Anderson Cooper from CNN did on 60 Minutes, did a whole segment with John Kabat-Zinn from UMass. And poor Anderson Cooper tried to be mindful for, I think he was at one of John's 3-day training, and he had to give up his phone and his iPad, and he was really struggling, but it was really cute. But it just showed that mindfulness is just like everywhere. Everyone's talking about mindfulness. It's what we know from the research. I'm just going to stay with the behavioral research right now. Is that in middle class educated parent groups, mindfulness has been shown to really improve parenting skills and parenting resilience. In terms of pregnancy, it's Nancy Burdacki out at UCSF has done tremendous research showing that there are better outcomes for couples who do mindful-based pregnancy and parenting and that the outcomes, people report less pain during labor and delivery. There's an increased bonding effect with the child, shorter hospitalization, less NICU time. So Nancy and Larissa Duncan, her partner in this research, have published a great deal on that. In schools, we know that really mindfulness has been very conducive to learning and to reducing child stress in the classroom, because our kids are coming to school really stressed for a myriad of reasons. And teachers are saying there's more of an ability for children to pay attention when they sit with mindfulness. Although right now there's some reactivity about mindfulness in the schools by some parents. So it was moving kind of nicely, but there's some communities that really don't want mindfulness being brought to their children. So what we're doing with mindfulness, and these parents are here are the 5 tenets that we're saying. We want to help them develop the ability to nurture, to learn to attune to their child, to be aware of their own thoughts and feelings, and that of their child as separate, acceptance of themselves, really allowing them to accept themselves for what they are, and to not wrestle with that while they're caring for this child. And then as a result, being able to begin to respond to the child with wisdom, parenting wisdom. So here's our class. It's 2 hours, 12 weeks, and what our work is more and more being recognized for. We're the only mindful-based parenting intervention that has tried to have and has succeeded in having 3 sessions with the mom and the baby together in the meditation room. And if it's a baby, we're working with the mom to just breathe and look at the baby. Close her eyes, open her eyes, and see her baby. And just watch what her baby is doing, and then ask what they've seen. And this then breaks that the baby is a, piece of the father of the baby or the sister-in-law. And they begin to see the baby, and they're very, very happy in this moment, because joy does come up whenever we're able to be in the moment, no matter what our lives are like, and these women experience that. With the toddler, we're doing something different. It takes a lot of energy, but with the toddler, we're actually stopping the play when the play goes south between the mother and the child, and the play often goes south. The child may pick up a toy, and the mother might say, "No, that's a girl's toy. Here's a truck." Or the mother would say, "Oh, I wanted to play with the yellow blocks." So what we do is we try to separate, and we say, what would it be like to follow your child in this play? Something that we do this, but these moms don't have the skill. So and asking them to breathe the whole time they're with their children. Can they feel their breath in and out? Can they feel their whole body? And that helps center them in this moment. So those are the kinds of things we're doing. There's a strong focus on self-compassion. So when we talk about compassion, I usually say this. We often talk about the double arrow of pain. So my example, I bang my elbow, and what kind of a reaction do you have for me? Yeah, everybody's sympathetic, compassionate, there's empathy. What do you think happened in my head? Yeah, you all know. I said, "Oh, you're a jerk. You're clumsy. You hurt yourself." Well, that's the second arrow, because the first arrow was enough for the pain. I'm human. We're all human. We bump into things. We fall, some of us more than others. But the second arrow is the arrow we can break, which is the judgment, the self-judgment and the critical thinking about that. Because that really then just makes that whole situation worse. And it keeps me locked into that. Because then there's a whole bunch of things that are going on in judgment. It'll be a domino effect. So breaking that with these moms and focusing on self-compassion is huge. The other part of that, too, is don't forget in drug treatment, it's a lot about the storyline, right? You come to group, 12-step or whatever, psychotherapy, you're really forced to look at your story and to tell your story to the entire group and the therapist. Now, in this group, we're saying, not so much. In fact, we're saying, you do have a story, and that story is important to you, but we're going to ask you to let it go for the time being. We're going to ask you to let your history go and really bring you to the here and now. And look where you are. You're in drug treatment. You have custody of your child. You and your partner are trying to make it. You went back home to live with your mother in a safe environment. You're trying to get your GED. So bringing them to this and having them, teaching them not to hold on to that storyline is very important in mindfulness and for these women. But it's important for all of us. Because those of us who walk around with our storyline, you know, it's like, in the 5th job, am I going to think my department chair is like picking on me? In the 5th job I'm in? You know, what is your storyline? Examining your storyline and really challenging and letting it go. And Pema Chodron, who's a Buddhist nun, has this phrase that I kind of love, which is, there is the blue sky of all of us. That's really our story, is that there's goodness in all of us, and that's what we want to tap into. So we had to do a lot of adjusting of this mindfulness to the trauma history. Because in mindfulness, you do something, you focus a lot of the time on a body scan. Because most of us, and I'll ask you to think about this in yourself, how often when you're sitting at work are you aware that you have an entire body from toes to the top of your head? No. Or when you're in the shower, I know it sounds personal, but how many people are in the shower with you when you're in the shower? For me, it's like my whole department's in there. Excuse me while I reach for the shampoo. And I know that because half the time I say, did I wash my hair? I can't remember. And that might happen to some of you. Really coming to understand that their bodies are, as we get them to begin to focus on the body, we also have to pay attention to body trauma. And the majority of these women have had physical trauma and sexual abuse, and especially as children. So that may mean, for the majority of them, there has been no healing from that. So telling them to pay attention to their body without realizing what may be triggered, we may be re-traumatizing them. So being very careful about the body scan. So we don't do, in mindfulness, in MBSR, we do the body scan lying down. With this population, we begin sitting in a chair. And we never talk about internal organs as we do in MBSR. We stay very superficial in the beginning to try to get them to do this. Same thing with body movement, and this is another study I'm working on right now. We're putting a proposal together. You can't do a lot of movement with these young women because they have a lot of physical pain. One is the pain might have led them to, what's the trajectory? We don't know. Hypothetically. They might have had pain first, or they might have had trauma first. Did trauma lead to physical pain? Did physical pain lead to prescription? What's the trajectory? That's the new study we're writing right now to submit. Go ahead.
So is it something that you learned as you were doing the mindfulness?
Yeah.
The whole body thing?
No, we had no idea.
Oh.
We had no idea. And, John Kabat-Zinn trained me. Nancy Berdacki trained me. None of my training did it come up because nobody worked with this population. And in fact, this was the skepticism by the mindfulness community was pretty strong 6 years ago when I started writing this grant. It still is kind of, when I go to the conferences, people say, you did this with people who are in treatment for opioid addiction? It's kind of hard for them to even to get their heads around. So this whole thing about the body. Not only that, and another issue is it's how mindfulness teachers are great because they don't re-traumatize staff. But my counseling staff, we had to relook at that because the women feel that the people they come in contact with, and this is pretty much maybe a new American theme, that people are judging them. And it might be judging them not by just saying, do you have your insurance card? that may be, just rude or somebody who's really busy. But to somebody who's had the experience these women have, they do feel hurt. They don't process it as hurt. They process it as F you, B. And that's the way it comes out from them. But really, we're re-traumatizing them when we don't talk gentle and slow and as simple as we can. And so these were all things we had to do, including the literacy, because you can imagine mindful-based stress reduction, UMass Medical School, Jon Kabat-Zinn. I don't know if you've ever had an opportunity to read Jon Kabat-Zinn. None of his sentences are less than 6 to 8 lines long. You have to breathe in between a sentence that John writes. So changing the literacy level and changing the way we said things to them, that took a while. Practice adaptations are just that we teach people to sit and meditate for 20 minutes, and here we can't. It's got to be 5 because their attention spans are short, and what else happens to people who are on methadone? They fall asleep continuously. So all of that, and then getting them to do mindfulness in daily life has been the easiest thing. So they're changing the baby. We say every time you're changing the baby, that's your opportunity to practice mindfulness. Just be there with that baby. And it's a few minutes, and they do it, and they report that they do it. They graduate. We've had, I think we're up to 150 or 145 have graduated mindfulness. They take it for 12 weeks. Some of them ask to take it again. We let them take it again. And then if those women graduate the second time, they get scholarship to take mindful-based stress reduction at Jefferson, where they get a certificate. They do hands-on activities to make mindful crafts that they can use, glitter globes to settle themselves. And you could see we created a whole room. We took one of our conference rooms and made it mindful. And we do really big, pizza and cake for every celebration. The results. Here are some of the things. The women are getting younger. They're about 31 years old that come into the mindfulness. When we first started, it was more like 34, 35. They're primarily white, as is the opioid addiction epidemic. Although we're starting to see more people of color come into care for opioid addiction. They're usually not the heroin users. They're more Percocet, and that's what we're beginning to see. We're starting to see more Hispanic. But for the majority, it's really 78% are non-Hispanic. And the education is really, it's really split, 3 ways. There's some high school, some college. So that's where they are. They're single or they have a partner. And they, in fact, the women that come into mindfulness are in treatment about 1.5 years before that's really, those are the women that choose to at this point. And they have 4 kids each. That's an average because I've had several women in the group who have 8 to 10. And they're unemployed because you can't be in opioid treatment, really, in IOP, intensive outpatient treatment. You can't be employed. You just can't. It's so much work to be in treatment, and they have babies. And I talked about the ACEs before, so the red or burgundy, 57% have 4 or more ACEs. This is not changing. This has been the same since we began our program. About 40% report 1 to 3. We're now going to start, though. We're now going to take the ACEs. We take ACEs at baseline. We're now going to start taking it after mindfulness because there are some women who come in, I guess what you would call it, maybe denial. It's not even in their consciousness until after they start doing some of this work, what they've experienced.
How do you count the number of ACEs?
How do we count it?
I mean, so is it every episode of sexual abuse, or
No.
What do you do?
It's sexual abuse, it's violence, categories. So they choose violence in the home, they saw violence in their neighborhood, those kinds of things, yeah.
So that may not actually get at the quantification as much as you might want. So violence in the home may be highly variable for her mother's live-in boyfriend struck her once to continuing physical
Yeah, well, we would make the argument, because that's a good point, really good point. No. We would make the argument that if you're now 30 years old and that one incident is still right here for you, it's here for you. Not meaning, as opposed to someone who, they do get to report sort of extremes. They do get to report on extremes too. So, yeah, I mean, we need now to come up with new instruments that measure both ACEs, and we're measuring something we call PICS. Esther Chung came up with it when she worked with Jenny Culhane at Penn, is positive influences in your life too. And we're going to start doing the analysis on that because we think that's important as well. But 3 or more, the literature says, affects long-term health.
Do you count losses in the ACEs at all?
Death of a parent when you are a child. Mm-hmm. Yeah. And here's this is an interesting slide because the blue bar is the CDC's national data. The orange, red is the Philadelphia and our study sample. So you just go right to 4 or more. You can see how different our population, I don't know why that changed, how different our population is than regular, the average person in Philadelphia and the average person nationally. And what did we find? Okay, pre to post we found perceived stress decreased, the 5 facets of mindfulness primarily increased, awareness is trending towards it. It keeps going further and further, the significance is going down, so we're looking at that. It's becoming better. A differential emotional response is increased, and depression has not statistically increased, although we think by the end of this study we will see a 0.05 significance. This is the kind of theoretical explanation as we look at this. So the population, all of their sociodemographic, their ACEs, all contribute to the low quality of parenting. They have maladaptive parenting, and then they have this parenting behavior. And we looked at parenting behavior, stress, and the ACEs as moderators. And what we found, I'm just going to say one thing. Do you know KIPS? Keys to Interactive Parenting? A Delaware resident actually created this. NICHD supported her in this development, and they've endorsed this as a tool. It's probably the best tool to assess parenting quality. It's subjective and objective measures, and it takes a range of behaviors in as functional and non-functional. So it's very usable among different ethnic groups, cultures, and languages. It looks at things like sensitivity to caregivers' responses, all the way to promoting exploration and curiosity. So it's a very a really good indicator of parenting. This just goes to show you that this was time is pre to post test, and just shows that there's a large clinically significant change in the parenting quality and on all subscales from pre to post in this population. And then here what we're seeing is a 3-way interaction. This is pre to post ACEs, and attendance, so we'll call it a dose of mindfulness. And it suggests that participants with high ACEs and high attendance improve the best. So they had a high ACE category. They really felt that this program spoke to them. The conclusion of this, and I really spent too much time on it, is that the mindful-based parenting intervention is associated with significant improvements, and it contributes to really sparse literature surrounding the dose response of mindfulness, which is another study that's going in, because there really are no studies looking at what the dose needs to take. In our study, any attendance of 3 or more out of 12 improved mindfulness and the parenting equality. And mindfulness in pregnancy, I'm just going to say a few things. I did this the last time I was here, which is basically to talk about, we looked at race, inflammation, and psychosocial factors in pregnant women. And really what we found was that, this is not the right slide, let me go back. What we found was that trait anxiety was associated with a reduction in gestational age and increased risk for preterm birth, but only in our African American population. So that's what we found in our first foray into this data. Not that these are just these are clinic women, non-addicted population in the city of Pittsburgh. So we wanted to look at inflammation because we wondered, is inflammation in there somewhere between, you have anxiety, you have preterm birth, is inflammation in this pathway? So we came up with, it was actually my hypothesis. I said they would have increased immunological response or reactivity. I was wrong. They didn't. What ended up happening is they have blunted immunological response. And when you think about the literature of say what racism is, right? Of course, racism is how it affects the person. It's continual trauma and continual stress. So it's chronic stress from the outside that you can't control. So it makes sense that the immune response is blunted. And we said that, and then we thought, well, what could we do about that? And so one of the things we did was we came up with a mindfulness intervention, 6 weeks in pregnancy. Our question was, is it feasible to do this in an OBGYN clinic? We didn't know, so that's really what we wanted to test. We went to March of Dimes, Pennsylvania, and sold this to them. And they came up with a small pot of money that allowed us to do 4 classes over a year, 6 weeks. The practice said yes. The practice actually learned to help us recruit. They actually bought into recruitment, and I don't know if any of you have the experience of working in practices. To recruit for studies is one of the most difficult things you can do. The practice bought into it, and that some of it was because they liked me. So that was good. And then we said, can mindfulness in pregnancy reduce stress, anxiety, increase gestation? We couldn't do that in this little study. But we did want to think about that question. And so we had little incentives, little $25 gift cards to get women in. And what we found was that women were basically 25 to 35 years old. We did a good job because we were trying to get women at risk for preterm birth, so we got a good number of African American, half our population. They were split above high school and less than high school and more, but we had some PhDs and some attorneys in our class. They were primarily Keystone members, that's our Medicaid, and about more than half had WIC, and primarily Christian, and 20% Muslim. That's all we had in terms of religion, and 40% of this population now was receiving methadone in the intervention. And what we found was birth weight was good at the end when we looked at it. Birth weight was good. The time of delivery was not bad, early term. pre-pregnancy, BMI, and gestational weight gain. We had 15% preterm birth. We expected that these women were all predicted for whatever the clinical reason was by a clinical panel to be at risk for preterm birth. So we don't know what this means, but it's hopeful. Hypertension.
So do you think that they're self-selected, they're sort of at risk, but they also are agreeing to be in the program?
Yeah.
So does that suggest the ones who agree to be in the program are actually maybe at a little bit lower risk than those who can't reach at all?
Well, so it could be, but we really, when they recruited them, they said, how stressed are you? So it was the stress question that pulled them in. That's what we were really pulling them in for. So, that's an interesting question. But it is self-selected because we didn't do it randomly. So regardless, we can't answer that, right? I mean, that's what we know. And 5 were in NICU, but I said 40, on the left side, 40% were receiving methadone. So that's 5 in the NICU is small for, NICU 24%. So that probably makes sense. So that's the opioid addicted moms. And what we found was, so the blue bar is pre-mindfulness. The orange or brown is 60 days after the course ended, and the burgundy is 214 days on average after. And what we found was there was stress stayed low, that women reported using mindfulness as a way of controlling their stress, and I'll explain. It's very simple. Trait anxiety did better. The longer they did, they reported doing mindfulness on their own. Mindfulness increased. This was good news to us. Pregnancy in a warped research way. Let me say that. Pregnancy anxiety remained. We did not do anything about labor and delivery. We did not do any training. This wasn't like Nancy Burdacky's mindful-based childbirth. There had no childbirth in here. So we wanted to leave something untouched by this training, and so that's the area we left. I would really like to. We're going to do it differently next time. We're going to do mindful-based parenting and childbirth and parenting, and I'm sure that's going to end up coming down. The other interesting things are we just started looking at models, and we saw that total mindfulness, perceived stress, and anxiety all remained significant after adjusting for race, level of education, and WIC status. So this is just the beginning of us doing the more predictive modeling, and we didn't even get to look at controls yet, and we'll be doing that next. Just saying a couple of things about what's next. So a new study would be pregnancy, mindfulness in pregnancy, taking blood in pregnancy, cord blood, and looking at the immune response while they're going through mindfulness. That would be that's another one we're planning. And we're also doing this pain study. And the pain study, I do a shout out to qualitative researchers, and I'm not, even though I'm a social worker, I've never been a big fan, primarily because it's a lot of work. But we know so little about how people come to addiction. We get it in the brain. We know what happens in the brain, but we don't know what happens leading up to it. So this new study that it probably will be a Corey submission will look at the trajectories of their history. We have 100 pages of psychosocial data on these women because they're in treatment, and they have to do that. We have to do that for the state, the city, the federal government. Everyone has questions. So we have 100 pages where we can really delve into that, but do an in-depth interview too to see, and also to see where prescriptions came in on that. And how prescriptions came in. Did the mom give her medication to a child to get the child to school? in middle school because she said she had cramps and didn't want to go to school, or high anxiety and manifested as cramps. What were the precipitating factors? So that's another study. Lots and lots of work by this big team. We have a self-compassion study going in next month to look at what happens when we just do self-compassion work with the women. Do they improve their recovery? Oh, and the other we're looking at right now, I have 2 students who are looking at relapse in this population. And, I have a guess, but we don't have the data yet. So that's me, that's this. Sorry, I talked so long.
So a question that sort of follows from what Bill was bringing up in the first study you presented, where you briefly showed that the high attendance participants who also had many ACEs were benefiting more from those who had a lot of ACEs with lower attendance.
Right.
This is partly a research question, but also a very pragmatic question. Do we say anything about what distinguishes those 2 groups who were both high on ACEs, but one was more willing to engage than the other?
Yeah, that's interesting too. It is. I will say that what we'd like to do is look at what the ACE was, and look at if they still have trauma in their life, because some of the women drop out of this. Not a lot. If we get them to 3 weeks, we've got them. But in the first 2 weeks especially, there are some women that are saying, no effing way am I doing this. Yeah. And the message seems to be, I am not going there. Yeah, I think that's what we're seeing, but we don't know yet. So it's an interesting question, and why do more qualitative research? It begs the question for that. Thank you.
So are you doing some movement in your study of mindfulness?
The women?
Yes.
I have 2 more classes that we're doing with our no-cost extension. So we're going to do 2 more, but every group has made the findings more significant. So we're like KIPS wasn't significant. It was like borderline in the early, and then on certain of the aspects of KIPS. But as we keep going, more and more are clicking. So 2 more, and then I'm moving the mindfulness work into the drug treatment. It'll be part of the drug treatment. They'll have it as a regular group, and they won't get incentivized. But it'll be, because what I'm doing with Mater, the Maternal Addiction Treatment Program, is actually creating a mindfulness program for staff and for our patients. So all staff are taking MBSR. They don't have to, but it just so happens that everybody gets happier when they take mindfulness. So everybody is just taking it. And we have a consultant we're working with on mindful communication on the job, so that we treat each other nice and don't hurt each other's feelings, which I think is important when you're doing work with this kind of difficult population. So it's really, it's just really a little story for those of you that are left about my mindfulness. You have to practice this in order to be able to do it, right? So I have to drag my hiney to my cushion at 5:30 in the morning, and sometimes I don't want to, because it's not always easy to sit in the present moment and let stories go and let go of anger. Sometimes I want to hold on to it. It's been an old friend. But doing this, one morning I got up and I read the paper, and I was devastated on a Saturday morning. I was on my way actually to a mindfulness retreat, a silent retreat for the day, which is something that we do in mindfulness. And I was furious by reading the paper, depressed, worried about my grandkids and what kind of world they were going to live in. And I thought, yeah, well, you'll sit and you'll cry in this meditation day, and then, it'll pass. I know that. So I had to run to the Giant for some food for the potluck in the retreat. And I was running around the store. It was empty. It's my favorite time to shop. I don't shop. My husband does all the shopping, so I don't even know where things are. I need complete help from everyone in the store in order to find 4 things. I find my 3 things. I got to find pita bread. I don't even know where you'd find it. And I go down an aisle and I I guess I noticed that I look down at the ground when I walk a lot of the time, because I'm thinking, I'm not in my whole body. And I noticed this woman's shoes and then her pants and her little sweater, and I think, oh, I like that. And I thought, oh, you like it because she's dressed like you and you like to dress like that. And then I look up and she's stocking the shelves, and then I look up and she's wearing a habib. And she looks at me and I look at her. Nobody else is around. And I said to her, how do you wear that? What's the dimensions of your scarf? Is that okay if I ask you that? She smiled and she said, it's a rectangle. I like a pashmina, yes. I said, how do you put it on? She showed me. I said, oh, thank you. And she said, why? Why do you ask? And I just stood there and I said, I think I have to wear one. And that's what I felt when I stood there. And she said, she went like this. I went my way. She went her way. A few minutes later, I'm in the middle of looking for organic pita bread and reading everything. And she comes towards me. And I get up and I smile at her and I say, hi. And she said to me, you wear habib? And I said, yes. I think I should. I think we all should. And she said, I gift you one. And with that, I just started crying. And I said, no, we can't take a gift. We're American, We can, but we like to pretend we can't. So I said, yes, I will take your gift. And she started crying. And I said to her, I think we're going to be okay. And she said to me, oh, we are going to be okay. We are going to be fine. You come back, and when can you come back? And we made a date, and I came back, and she gave me a beautiful scarf. And she said to me, do not wear habib. You don't need to. She said, wear it here, wear it here. She just said, feel it when you wear it. And I said, yes. And she said, and I tell you something else, because I look at you, I cry, you cry. Let me tell you what I tell my children. It is not good now, but it will get better. So that's what I leave you with.